Welcome back guys. Now in this video, let's begin with the topic of distal convoluted tubule. Now distal convoluted tubule, which is simply called as DCT. Okay, DCT. Now in this distal convoluted tubule, the first point which I want you to know is what are the transporters present. Okay, in this distal convoluted tubule, see, now this is the lumen, this is the lumen, this is the place where urine is passing. Okay, from the ascending limb of loop of Henle, fluid is going to enter into the distal convoluted tubule. Now urine is coming down like this. Okay, now the urine is coming down like this. Okay sir. Now see, what is this membrane? This is called as the luminal membrane. Okay, this is the luminal membrane. Okay, now please appreciate that here in the distal convoluted tubular epithelial cells, the luminal membrane does not have any brush border. Okay, there is no brush border present. Okay, brush border is present in the PCT cells. Okay, now on this luminal membrane, see, there are two important transporters present. Okay, and on the basolateral membrane also. Okay, here on the basolateral membrane, two more important transporters present. So first of all, what are these transporters? Okay, that's the first important topic. Now one important transporter. Okay, this is the transporter number 1. Now what this transporter is doing? It is taking sodium ions into the cell. The sodium and chloride ions into the cell. So sodium is moving in and chloride is moving in. So sodium chloride symporter. So direct MCQ, sodium chloride symporter is present on which part of the nephron? Distal convoluted tubule. So sodium is moving, along with that chloride is moving. So symport. So all symporters are example of secondary active transport. Okay, all symporters are example of secondary active transport. Okay, now after this, what is the second important transport? The second important transporter is this, okay, which I am showing you this. Now, what is this transporter doing? It is going to take the calcium ions. This is not the chloride, it's a Ca. Okay, it is going to take the calcium ions and the calcium is going to enter into the cell. Okay, point is already the calcium levels inside the cell is more. Already more and more calcium is there inside the cell. Now, if you want to move the calcium from low concentration to high concentration, okay, you are now moving the calcium from low concentration to high concentration. Why? Because in the cell the calcium concentration is more calcium is there. Okay, so calcium is moving from low concentration to high concentration. So what you need to do? You need to use the ATP. So this is a pump. Okay, this is a pump. So pumps are like, using the energy. Pumps are going to use the energy in the form of ATP. So this is the calcium ATPase. This is the calcium ATPase pump, which is also called as TRPV5 channel. TRPV5. Okay, TRPV5. So transient receptor potential vanilloid calcium channel 5. Okay, no need to remember the full name, but simply, sir, calcium ATPase or simply TRPV5 channels are also present on the luminal membrane. Okay, now let's talk about the transporters which are present on the basolateral membrane. Okay, which transporters are present on the basolateral membrane? See, two important transporters are there. Now, what these transporters are doing? Please appreciate. Now, what is happening here is, now this transporter is taking the potassium ions into the cell. See, now the potassium, it is going into the cell. Potassium is going into the cell. How many potassium are coming into the cell? 2 potassium are coming into the cell. And what is happening to the sodium? See, these 3 sodium ions are coming out of the cell. Okay, 3 sodium ions are coming out of the cell. So what is the name of this transporter? Your favorite transporter. It will come everywhere. It's there on every part of the body. So this is sodium potassium ATPase, which moves the 2 potassium ions into the cell. Okay, it throws 2 potassium ions into the cell and takes 3 sodium ions out of the cell. Okay, so this is sodium potassium ATPase. Why ATPase? Why? Because see, already the sodium concentration in the cell is more. Okay, more sodium is coming into the cell. Okay, via this route, see, more sodium is coming into the cell. Okay, more sodium is coming into the cell. So what happens? Now already inside the cell. Okay, already inside the cell. Now what is happening is, I should teach you something like this. See, why the sodium is coming into the cell? The sodium is coming into the cell because, see, the sodium potassium ATPase, what it is doing? The sodium potassium ATPase is all the time taking 3 sodium ions from the cell to the interstitium. All the time 3 sodium ions are going out of the cell. Okay, going out of the cell. So what happened to the intracellular sodium concentration? The intracellular sodium concentration is going to be decreased. So remember, now in the DCT epithelial cells, the sodium concentration is low. Sodium is kept low inside the cell. Now here, low concentration of sodium is there. Why? Because 3 sodium ions, say, they are going out of the cell. So what happened to intracellular sodium concentration? Intracellular sodium concentration decreases. Okay, decreases. So that's why, see, now sodium will enter into the cell. Okay, now from this high concentration to low concentration. Inside the cell, the sodium concentration is kept low. See, sodium levels kept low inside the cell. So that's why, see, the sodium is coming into the cell. Point is, now you can ask me, sir, intracellular sodium levels are less. Okay, you are saying intracellular sodium levels are less. But now this sodium is coming along with the chlorine. Sodium is going to come into the cell as well as the chloride. Now you have taught us like this sodium chloride symporter. It's an example of secondary active transport. Okay, previously we have also discussed that the sodium chloride symporter is an example of secondary active transport. Secondary active transport means energy is needed. Now you can ask me why energy is needed, sir. Okay, why energy is needed? Now here intracellular sodium levels are less, no doubt. Now sodium here is moving from high concentration to low concentration. Sodium is coming in. Why? Because inside the cell sodium levels are low. So for this moment, why? For this moment, why do you need the energy? Yes, see here energy is not directly utilized. Okay, energy is not directly utilized. That's why I said you secondary active transport. If energy is directly utilized over here in the form of ATP, then it is called as primary active transport. But see, yes, sodium is coming in. But why it is coming in? It is coming in because intracellular sodium levels are kept low. Who is keeping the intracellular sodium levels low? Sodium potassium ATPase. See here ATP is getting utilized. Okay, with the help of ATP, sodium is going out of the cell. That keeps the intracellular sodium levels. Okay, that makes the intracellular sodium levels low. So that's why sodium is going to enter into the cell. So this is an example of secondary active transport. Okay, secondary active transport. Okay, now after that, let's talk about the fourth important transport, the fourth transporter. Okay, the fourth one. What is this? Now see, it is taking the sodium into the cell. Okay, now sodium is coming into the cell. At the same time, see the calcium, it is going out of the cell. Okay, calcium is coming out of the cell. So can I call this an exchanger? Yes, this is an exchanger. Which exchanger? This is sodium calcium exchanger. Now this fourth transporter, it is taking the sodium ions into the cell. Sodium is coming in. Now the sodium is exchanged for calcium. Now calcium is going out. So this is also secondary active transport. Wherever you see, like symporters, antiporters, exchangers, any word, two ions are moving together or in opposite direction. That's an example of secondary active transport. Secondary active transport. Now here my question for you is, sir, by how many ways sodium is coming into the cell? How many ways sodium is coming into the cell? You need to know. See, sodium is coming into the cell via this transporter, sodium chloride symporter. Not only that, sodium is coming into the cell with the help of this sodium calcium exchanger, the sodium calcium exchanger. See, the sodium calcium exchanger, it is also bringing sodium into the cell. So sodium is constantly being brought into the cell via two routes. Just know this point, later we will discuss, okay, much about it. Okay, for now I want you to know there are two ways by which sodium is coming into the cell. Okay, now after this, let's talk about certain conditions where some of these transporters are activated, some of the transporters are activated. Now the condition here is hypocalcemia, in the conditions of hypocalcemia. So what exactly is hypocalcemia? The blood levels of calcium are going down. The blood levels of calcium are going down. When the blood levels of calcium goes down, yes, hypocalcemia is there. Now that hypocalcemia is going to activate the parathyroid gland, the chief cells in the parathyroid gland. Now the parathyroid glands are going to be activated. They are going to produce which hormone? Parathyroid hormone, PTH, parathyroid hormone. Now this parathyroid hormone, what it will do? Now this parathyroid hormone, see, it's going up like this. Where it is going? Actually here, it's like, it got little cut. See, the parathyroid hormone, now it will come and it will activate. The parathyroid hormone is going to activate the sodium calcium exchanger. So where exactly parathyroid hormone is going to work? In the nephron, the parathyroid hormone acts on the distal convoluted tubule. Okay, it also acts on the proximal convoluted tubule, but there the function is different. Now parathyroid hormone, it acts on distal convoluted tubule. Now in distal convoluted tubule, where the parathyroid hormone is going to activate the sodium calcium exchanger. It's going to activate the sodium calcium exchanger. Now when the sodium calcium exchanger is activated, now what happens? See, now more and more calcium is going to enter into the blood. So the problem is treated or not? The problem is hypocalcemia. Now in hypocalcemia, parathyroid hormone is there. Now this parathyroid hormone is going to activate the sodium calcium exchanger. It's going to activate what? It's going to activate sodium calcium exchanger. Okay, it's going to activate the sodium calcium exchanger. Now when the sodium calcium exchanger is activated, so what happened to the calcium reabsorption? Calcium reabsorption is going to be increased. The more and more calcium is going to be reabsorbed. Okay, now Yeah, we have already seen the DCT transporter. The 4 important DCT transporters are there. Sodium chloride symporter, TRPV5 channel, the calcium, calcium ATPase calcium channel, sodium calcium exchanger, as well as sodium potassium ATPase. Sodium potassium ATPase, these are the 4 important channels which are present on the distal convoluted tubule. Okay, now please look at here, the calcium reabsorption is regulated by the parathyroid hormone. Where parathyroid hormone is going to act? Parathyroid hormone is going to act on the distal convoluted tubule. It increases what? It increases the activity of sodium calcium exchanger. Not only that, it increases the number of sodium calcium exchangers. Okay, under the influence of parathyroid hormone, more sodium calcium exchangers are going to be produced. Okay, so more sodium calcium exchangers means more calcium reabsorption into the body. More calcium reabsorption into the body. Now let's talk about a little bit important about the pharma. Okay, pharmacological integration. So what is that? Now thiazide diuretics. Okay, there are these drugs called as a thiazide diuretics. Diuretics means diuretics, double the urination, more urination. They will cause more urination. So there are these drugs called as thiazide diuretics. Okay, what they will do? Now these thiazide diuretics. Okay, what they will do is they will inhibit. 2 points are there. The thiazide diuretics inhibit. The first important point is the thiazide diuretics inhibit. Write this. Inhibits. Okay, sodium chloride symporter. Okay, so sodium chloride symporter is inhibited by thiazide diuretics. Now you will get it out. What is the sodium chloride symporter? Now this one, this fellow. Okay, now when you give this thiazide diuretics, what happens? Now this thiazide diuretics, they will come and they will inhibit the sodium chloride symporter. Okay, now because of this, there will be more diuresis. Okay, now that's not important. My point here is, when you use thiazide diuretics, there is a statement. Okay, when you use this thiazide diuretics, calcium reabsorption increases. More calcium will be reabsorbed into the body. How? See, loop diuretics, when we are discussing about the loop diuretics loop out the calcium from the body. Loop diuretics takes the calcium out of the body, puts more calcium into the urine. In the urine, the calcium will precipitate and form the stones. Okay, well and good. But this thiazide diuretics, do you know what they will do? They increases more calcium reabsorption. How? See, the thiazide diuretics, okay, they will come, they will inhibit this transporter. Okay, they will inhibit the sodium chloride symporter. Okay, well and good, sodium chloride symporter is inhibited. So what happens? See, now the sodium is not coming into the cell. Okay, sodium is not coming into the cell. I have already asked you to remember, see, there are 2 ways by which the sodium is going to enter into the cell. This is one way. Okay, this is one way. Now this is the other way. Now what happened? Now one of the way of the sodium, entry into the cell is blocked. So one way is blocked. Now sodium is not coming to the cell. So now what happened to the sodium concentration inside the cell? The sodium concentration inside the cell is now getting very, very less. Normally, what this transporter should do? What is this transporter? Sodium potassium ATPase. Normally, sodium potassium ATPase have to take the sodium from the cell and have to throw out. Now, see, sodium is not entering into the cell. So there is no enough sodium available for the sodium potassium ATPase. Now, sodium is not there. Okay, sodium entry into the cell is decreased. Now, the sodium potassium ATPase is worried. Why? Why? Because intracellular sodium levels are going to go very, very less. So that if sodium levels go very less means now it will not function. Okay, why? Because it have to take the sodium out of the cell, right? Now, sodium is not available. Now, if sodium potassium ATPase are not working means that is very bad. Okay, that's very bad. The membrane potential cannot be maintained. Everything will be changed. So now what you need to do? You need to bring more sodium into the cell. Now you need to supply more sodium into the cell. So how can you supply the more sodium into the cell? Now there is the second way. This is the second way by which more sodium will come into the cell. What is this? Sodium calcium exchanger. Now this sodium calcium exchanger will start to work more. Now during this process, see, now it will try to supply the sodium for the sodium potassium ATPases. Now more and more sodium is brought into the cell. Okay, more and more sodium is brought into the cell, which means more and more calcium is reabsorbed. More and more calcium is reabsorbed. Okay, in order to bring more sodium into the cell, it is reabsorbing more and more calcium. So this is how thiazide diuretics will increase the calcium reabsorption. So thiazide diuretics increases the calcium reabsorption. Okay, so that's the important point which I want you to know. So calcium, if a patient is having recurrent nephrolithiasis, okay, if the patient is having recurrent nephrolithiasis, which means, for example, imagine that there is this one patient who is having kidney stones. It's coming every time the doctor is doing the surgery, and still again they are recurring again and again. So which means in his urine more calcium is there. That calcium is getting precipitated and it's forming the calcium oxalate stones or calcium phosphate stones. Now what you need to do, you need to decrease the amount of calcium in the urine. You need to decrease the amount of calcium in the urine. So how can you decrease the amount of calcium in the urine? By increasing the reabsorption. You can increase the calcium reabsorption so that the urinary concentration of the calcium will be decreased. Okay. So in that conditions, if the patient is having recurrent nephrolithiasis, in those patients, you can use drugs like thiazide diuretics. Question is, thiazide diuretics acts on distal convoluted tubule. Thiazide diuretics inhibit, okay, sodium chloride symporter. Thiazide diuretics are used in the treatment of nephrolithiasis. Not only that, imagine this patient is having idiopathic hypercalciuria. Okay, calcium is going out of the body unnecessarily. We don't know the reason. Calcium is going out of the body. So that causes what? Hypocalcemia in the patient. Hypocalcemia, which is not good, which will cause a tetany. So in a patient who is suffering with hypocalcemia, we can use drugs like thiazide diuretics. Why? Because thiazide diuretics increases the calcium reabsorption. Okay. So these are some important points which I want you to know regarding the distal convoluted tubule and important transporters. Now after this, let's discuss about a syndrome which is called as a Gschittleman syndrome. Now one small mistake is there. It is, okay, I will discuss anyway. See, now sodium chloride symporter, yes, we have discussed. The sodium chloride symporter on the DCT is blocked by thiazide diuretics. Okay, well and good, true. Now the sodium chloride symporter mutation. Okay, now there is this one baby. By birth itself, the sodium chloride symporter is not functioning. Okay, the sodium chloride symporter is not functioning. Then the syndrome is called as Gschittleman syndrome. Okay, or Gschittleman syndrome. Okay, okay, so done. Now, see, this Gschittleman syndrome, it's an autosomal recessive disorder. Okay, autosomal recessive disorder. Now, tell me, see, if you use thiazide diuretics, which transporter is affected? Sodium chloride symporter is affected. In Gschittleman syndrome, which transporter is affected? Sodium chloride symporter is affected. So now Gschittleman syndrome, it resembles what? Now Gschittleman syndrome, it resembles thiazide diuretic overusage. So it resembles thiazide diuretic. Okay, so it resembles what? See, there is a small typing mistake. It resembles thiazide diuretic. It resembles thiazide diuretic overusage. Because in both the condition, same transporter is affected. So same clinical features are seen. Okay. Now, what are the clinical features if you ask me? Sir, in this Gschittleman syndrome, yes, sodium chloride symporter in the kidney is affected, in the DCT is affected. Not only that, TRPM6 channels. Okay, TRPM6 channels, which are the magnesium channels. Okay, magnesium channels. Now, these magnesium channels are also affected in the nephrons. So, what happens? More sodium is going out in the urine. Okay, more chlorine is going out in the urine. More magnesium is going out in the urine. So, natriuresis, calciuresis, okay, magnesuria, all, like, these substances are lost in the urine. So what happens, sir? Now the sodium which was supposed to be reabsorbed in the DCT, now it is going out in the urine. Now wherever sodium goes, water follows. So this patient, this baby, now is neonate. Now this fellow is having dehydration. Polyuria is there. That will cause us dehydration. Severe dehydration is going to be seen in this baby. Okay, excessive urination. This baby is going to produce excessive urine, polyuria. Okay, so this dehydration will be visible as the sunken anterior fontanelle. If you look at the anterior fontanelle, that will be sunken. Same clinical features. Even in the Bartter syndrome also we have seen the same clinical features. Sunken anterior fontanelle, polyuria, okay, dehydration, failure to thrive. Okay, but there in Bartter syndrome, important point is, see, in Bartter syndrome, the patient is having defective chloride channels even in the ear. That will cause sensorineural hearing loss. In Bartter syndrome, the patient is going to have sensorineural hearing loss. But here, important point is, this fellow is having a mutation of TRPM6 channels. Now, this TRPM6 channels are mutated, so more and more magnesium is going out in the urine. More magnesium loss is there in the urine. Now, whenever there is more magnesium loss, see, important point is magnesium is very much needed for the production of parathyroid hormone. So, this fellows doesn't have the parathyroid hormone. Now, when the parathyroid hormone is not there, normally parathyroid hormone tries to increase the blood calcium levels. Now these patients or these babies does not have parathyroid hormone. When the parathyroid hormone is not there, they will suffer with severe hypocalcemia. Severe hypocalcemia is there. Okay, so see, serum magnesium levels decreases. So if they are talking about a neonate, polyuria, okay, polyuria, dehydration, failure to thrive, sunken anterior fontanelle with low magnesium levels, you should think about Gschittleman syndrome. You should think about Gschittleman syndrome, where the serum magnesium levels are going down. Even the parathyroid hormone levels goes down. Why? Parathyroid hormone levels are going down. Why? Because for the production of parathyroid hormone, you need to have the magnesium. No magnesium, no parathyroid hormone. That will cause severe hypocalcemia. Severe hypocalcemia is going to cause tetany. Okay, tetany, muscle contractions. Okay, even the patient can go into the opisthotonous position. Like something like this. The entire body will be bent. Okay, he might look like a possessed person. Okay, possessed, something like devil possessed person. Okay, so there will be severe hypocalcemia, that will cause the tetany. Okay, yes, we have discussed there is sunken anterior fontanelle. If you look at the BP, what is the BP? Now this patient is losing the urine, right? This patient is losing the lot of fluid out of the body. More polyuria is there. What happened to the BP? The BP will be normal or it may be decreased. Okay, it may be normal or it may be decreased, but it is never increased. Remember, even when we are discussing about the Bartter syndrome, same. BP is normal or decreased, but it is never increased. And this is also autosomal recessive. Bartter is also autosomal recessive. Now same, failure to thrive, polyuria, dehydration, sunken anterior fontanelle, same things. Okay, so these are the some important points which I want you to know regarding the Ghitelman syndrome. Now after this, let's discuss the differences between proximal convoluted tubule and distal convoluted tubule. So how to differentiate histologically? See, histologically, the proximal convoluted tubule is lined by the simple cuboidal epithelium. Even distal convoluted tubule is also lined by the simple cuboidal epithelium, but here in the proximal convoluted tubule, see, there is brush border which will increase the surface area. Brush border is there, okay, for the epithelium. Now in the distal convoluted tubule, see, there is no brush border. Okay, now in the proximal convoluted tubule, in between the cells there is gap, so there are leaky junctions are present. Okay, in between the cells the gaps are present, they are the leaky junctions through which the water is reabsorbed. Okay, water reabsorption happens. This is called as a paracellular route of water reabsorption. So paracellular route of water reabsorption possible in the PCT. Why? Because in between the cells some small gaps are there, so water is reabsorbed. Okay, but in DCT, no, there are no gaps between the cells, Okay, as there are no gaps, we'll call them as tight junctions. So tight junctions are seen in the distal convoluted tubule. And no gaps are there, so no paracellular water transport, but paracellular water reabsorption happens in PCT. And in PCT, one more important difference is there are two types of carbonic anhydrase. Okay, two types of carbonic anhydrase, that is type 2 as well as type 4. Okay, both 2 as well as 4, type 2 as well as type 4 carbonic anhydrase are present. But in distal convoluted tubule, only type 2 carbonic anhydrase is present. Okay, only type 2. So these are some important histological differences, which are seen between histological as well as the biochemical differences seen between the proximal convoluted tubule as well as the distal convoluted tubule. So with this, the topic of distal convoluted tubule is completed. Hope the video is helpful. Thank you.